Yeah, thank you very much, Dr. Rao. I think that was a very comprehensive presentation. I think we are in no doubt as to how to approach COVID-19 with coagulation problems. We'll take our next presentation. That will be from Selma Adomako. Selma is a senior nursing officer at the Child Health Department, Kolebu Teaching Hospital. I think one of my first encounters with Sister Selma was at Kolebu whilst I was washing my hands at one of the taps. And she approached me and asked me, "Doctor, is that how to wash your hands?" And she quickly showed me how to properly wash my hands, and it stuck with me till now. So what she's going to talk about is infection prevention and control in pediatric COVID. So Selma, if you are ready, please go ahead. Can you see your slides? Okay. Hello, Selma.
Hello, good morning, everyone.
Good morning.
Hello. Good morning, Mr. Chairman, and all protocols observed. As Dr. Burma said, my name is Selma Opon Adomako, and it's my pleasure this morning to present this bit of information on infection prevention and control. Cyprian, thanks for the intro. I don't remember that too, but thanks. I hope everybody can hear me, please. Okay, so
yes,
we are talking about, okay. We are talking about infection prevention and control, which is a practice that we all undergo daily. But when it comes to COVID, we can't underrate infection prevention and control. With COVID comes a high level of practicing proper hygiene techniques all over the place. Previously, you won't go to any office or any company and see anybody checking temperatures or hand sanitizer or washing basins over the Veronica buckets to wash your hands. But because of COVID, it's all over the place. So we have to strictly adhere to some of these practices so that we really curtail the spread of the infection and battle it as we are here in the second wave with all its great harm that is causing everybody all over the world. So when it comes to the guiding principles for IPC, we have the early recognition of patients. You know, at the OPDs, we usually do screening and triaging of patients. We take good medical history and then proper documentation. We realize that some of these bits of information Hello. Hello.
Hello, Selma. Sorry for the technical
Yes.
hitch. You are back on.
So
yes.
I was okay, great. So when it comes to triaging at the OPDs, is very, very essential. And some bits of information that were not important some years and months back have become important, like travel history and all that, and fever and all that. Fever was important, but travel history, for instance, wasn't so important. But when it comes to COVID, it's very, very essential. And then application of standard precautions for all patients. You know, we have been doing it, something that's been ongoing for months now. Hand hygiene among staff, visitors to the hospitals, and healthcare givers, relatives, and all that. And then respiratory hygiene. Respiratory hygiene, we have what we call the catch it, kill it. You catch it in a tissue, wash your hands. Okay, when it comes to soil, let me go back to the hand hygiene, proper way of hand hygiene, hands properly. Some people come, they just open their taps, wash their hands and don't apply much soap or don't lather well and then wash. There's a procedure for doing that. So we have to ensure that it's properly done among ourselves, the patients and the relatives. And then the waste management, proper packaging of waste, laundry and hospital care equipment from especially isolation centers. You know, previously everything is just taken and dumped. But when it comes to COVID, what's the name? COVID waste, it's different, entirely different procedure that is taken to process them and then take them to the right place, and the laundry as well. And then needle stick injuries, we should avoid it as much as possible. We should not recap needles. We should not. You have no idea what you're putting yourself through when you get pricked by that needle. So appropriate use of PPEs. At any point in time when healthcare workers are going to use PPEs, we have to assess the risk, assess the type of patient or what exactly you're going to do, and wear the right amount of PPEs so that one, you're protected, and also two, we avoid wastage. Environmental controls like cleaning and disinfecting of hospital environments. There's a lot of work going on in that regard. And then employing the use of the right or the appropriate disinfectant. You know, when it comes to disinfection, the appropriate amounts or the quality of disinfection or the type has to be used, so that it's all about spread and prevention of the condition. And we are also told here that we should avoid spraying because it increases the risk of aerosol generation. And it has no spraying, has no proven disease control benefits. So when we have to clean the walls, clean the beds, the equipment, everywhere, not spray because of aerosol generation. And a HEPA filter should be used where a vacuum cleaner needs to be used. It has to have a HEPA filter. And then transmission-based precaution. That's patient with presumptive diagnosis. So when it comes to the patient, we categorize them and attend to them rightly. Isolation of patients. We should observe social distancing in isolation wards and isolation units. Proper ventilation, that one cannot be underestimated. Okay, proper ventilation, okay. Okay, so I was on ventilation, okay. And explain the importance of IPC to workers and then to patients as well. Appropriate assessment of patients and the right use of PPEs at the right time by the healthcare workers. And then it's also documented that surgical masks do not provide adequate aerosol protection. That's the droplet nuclei. So when attending to COVID patients, the N95 or the FFP3 is advised. You can use the surgical one on the general wards, but for attending to COVID patients, the N95 or the FFP3 is advised. And then every facility, as we are now seeing almost all over the place, should have an IPC infrastructure where all these tried and tested protocols would be used to save the situation at any point in time. And then these few things are quite essential. I've talked about hand hygiene already, but one thing that I want to add here is that, you know, some mothers come with long fingernails because life, you know, they are trying to look good. But then when you're having a child with such an infection, I think it's also advisable to keep your fingernails trimmed like we the healthcare workers do to prevent spreading of infection, so that they are well kept, and then it helps to prevent more infection going from mother to child or any other way. And then we should also avoid touching the face, the eyes, the nostrils, and the ears with our hands. We can advise that to the parents and the children, mother and child or caretaker and child as well. Cyprian, can you please go up? Cyprian, can you please go up? Okay, so respiratory hygiene, catch it, bin it, kill it, as I've said already. And also we should avoid coughing and sneezing in our face mask, because you're supposed to cough it out, not cough it and breathe it. Sneeze it out, not sneeze and breathe. So we avoid coughing. We do the catch it, bin it, and kill it, as I've explained earlier. And also we should avoid the masking. We should avoid touching the front of the mask, because this is the place where whatever is coming from others or the atmosphere around us is attracted to or is caught on. So when you touch the front of your mask, you are just infecting yourself if there's anything there, and you're going to touch some part of your body or somebody with it, and it's going to be spreading and not protecting. So you should wear the mask appropriately. Where there is difficulty in breathing, sometimes you usually you can't wear the mask for 8 hours without catching your breath, taking it a moment to eat or drink or catch your breath. So when you're finding it a bit difficult to breathe, you can just move away from a crowd, bend your head a bit, or in an isolated place where you're alone, take it off, catch your breath, and then put it back on. Do it appropriately as well. And we should always wear the mask to cover our nose and our mouth, not just our mouth. And we shouldn't do the chin masking, the earlobe masking, etc. We should avoid all that. Social distancing. Attending to patients is always one thing that you can't really do proper social distancing all the time. When you're going to give an injection, you're doing some other procedures on the patient, you can't really do. But as much as possible, because we are aware now that social distancing helps a lot when it comes to infection prevention and control with regard to COVID-19. So in as much as we can, we should do it when it is very possible for us to do it, so that we reduce our risk of getting infected and infecting others as well. Now, self-isolation. Patient in self-isolation should remain isolated, avoid visitors or avoid visiting others. Some people are not able to do that. Some other presenters have mentioned about children who are asymptomatic but have COVID and they are taken home, and you realize there's so much interaction. Somebody's in a compound house and so much interaction, but the child is supposed to have COVID and be isolated. But that is not being adhered to. So we have to avoid visitors or visiting when they are patients in the house with COVID-19. And where possible, self-isolation, where possible, patient in self-isolation should have one dedicated carer who will be meeting his or her need. And that carer should also be in a form of self-isolation. If that carer is tested positive, she also has to undergo treatment, and the necessary precautions should be taken. And every patient should adhere to the COVID-19 medications or whatever medications they are given. Strictly adhere to it. Take the medicine on time. Take the medicine appropriately. If it's before or after meals, take it to get better at the right time. Well, this is my bit on infection prevention and control. And this is a document by WHO, which was adopted by Lomotey Teaching Hospital as well. So this is what I have to present today. Thank you very much, everybody, for your audience.
And thank you to Selma Opon Adomako for a wonderful presentation on IPC. Okay, so we'll take the next presentation from Dr. Nana Broby, Nana Reku Broby. She's a pediatrician and a neonatologist with a mother and baby unit at the Konfanochi Teaching Hospital. She's going to talk to us about management of the newborn with respect to COVID-19. So Dr. Reku Broby, if you are ready, please go ahead.
Okay, good morning, everyone. Cyprian, I hope my slide is showing well.
Yes, it's visible and we can hear you clearly.
All right, okay. So good morning, everyone. I hope our Saturday morning has been pleasant so far. I've been tasked with taking us through management of COVID-19 in neonates. So I hope that I'll be able to do a bit of justice to it. So this is the outline. Quickly going to go through the introduction, a bit of local statistics, clinical features, etc., etc. Okay, so by way of introduction, the transmission of the SARS-CoV-2 virus that's responsible for causing COVID to neonates is thought to occur primarily through respiratory droplets. And this typically occurs during the postnatal period when neonates are exposed to mothers or other caregivers with a COVID-19 infection. Now, limited reports in the literature have raised concerns of possible intrauterine, intrapartum, or peripartum transmission. But the extent and clinical significance of vertical transmission, which appears to be rare, is unclear. Current evidence suggests that COVID-19 in neonates is uncommon, or should I say not as common or as severe as compared to the adult population. However, if neonates do become infected, the majority have either asymptomatic infections or mild disease, and they do recover. Now, there's a lot of theories out there as to why neonates are not affected as severely as adults, but two of the theories are most popular. The first one is focused on the on the immaturity of the immune system, which renders the neonate incapable of producing a cytokine storm, like Dr. Fuseni talked about earlier. And then the second one is based on the reduced number of angiotensin converting enzyme 2 receptors, which are supposed to be the viral receptors for the COVID virus. So the ACE2 receptors are generally found in the lungs and the enterocytes in the gut. The theory says that it's possible that the ACE2 tissue distribution differs between adults and children, and the maturity and function, for example, like the binding ability in children and babies may be lower than that in adults. Of course, these are just theories and many more are coming up. So severe illness in neonates, including illness requiring mechanical ventilation, has been reported, but fortunately appears to be rare. However, it's worth to note that neonates with underlying medical conditions like congenital heart diseases and preterm infants may be at higher risk of severe illness from COVID-19. So just a few statistics from Confanoche MBU. Since we have already been taken through the general overview with the numbers, both locally and globally. Yesterday, Dr. Adabie took us through all that. I figured I'll just mention the data that we have collected at CAF MBU. So as of the 16th of March this year, these are the figures we've had since last year, April or so. The total number of mother-baby pairs that have been tested is 40. Okay, of the babies, we have 18 who are male and 22 who are female. We've had 2 babies who have tested positive. Okay, so of the 2 babies, one of them tested positive with the mother. And then the second one, only the baby was positive. The mother turned out to be negative. The number of positive mothers is 5 so far. The youngest was 10 days old and the oldest 5 weeks old. So we admit up to 2 months old. And all of them is the real-time PCR that have been used on either nasal or nasopharyngeal swabs. Clinical features were mostly cough, rhinorrhea, fever, and increased work of breathing. Both positive babies were females, one a late preterm and the other a full-term baby. The highest respiratory support we had to provide was the bubble CPAP. Of course, there's also the possibility that we've missed quite a number of these mother-baby pairs, especially those who would have been asymptomatic and couldn't have been picked up from the very beginning. So generally, clinical features in neonates, you have, especially in preterm infants, might be non-specific and include acute respiratory distress syndrome, temperature instability, GI and cardiovascular dysfunction. But generally, commonly reported signs of COVID-19 infection in neonates include your fever or temperature instability, lethargy. Occasionally, you might have rhinorrhea, especially those who are more than 4 weeks old. There could be cough as well. And then there could be increased work of breathing. So you have your typical signs of distress like flaring, grunting, intercostal, and lower chest indrawing. There could be GI symptoms as well, like vomiting, diarrhea, and then poor feeding. Now, the problem is that the extent to which COVID-19 infection contributed to the reported signs of infection and complications is unclear. So as many of these findings are common in term and preterm infants for other reasons. So you can have your typical baby coming in with transient tachypnea of the newborn and can present with some of these features that I've mentioned. Or you can have your preterm baby coming in with respiratory distress syndrome as well, also with similar clinical features. So when you come to management in neonates for COVID-19 is typically symptomatic. Let me reemphasize that there are currently no specific treatment modalities for COVID-19 in neonates. No antimicrobial has been proven effective. No antimicrobial, no antiviral has been proven effective for the treatment of COVID-19. Hence, empirical antibodies should not be started just because one is worried about COVID-19. A baby who is born to a mother with suspected or confirmed COVID-19 should be managed as per any other respiratory pathology. Fortunately, very rarely do the COVID positive neonates require mechanical ventilation. So at least we can provide some kind of respiratory support. Preferably, it's recommended that the baby is nursed in a closed incubator, of course, with the use of appropriate PPE by the staff. And for babies that need to be transported, it would be preferable to do so in a transport incubator. The teaching is that babies should be considered potentially infectious for 14 days from symptom onset. Of course, there are numerous challenges in enforcing the isolation, especially in terms of space in our hospital setting, but we need to do the best that we can. So just a few general principles of management. Delayed cord clamping for 30 seconds to 1 minute is still recommended for babies not requiring resuscitation. Now, it's very important to have a member of the delivery team skilled in neonatal resuscitation, since for very ill positive mothers with severe pneumonia-like symptoms and hypoxemia, the fetus could become distressed and come out asphyxiated. Of course, bearing in mind that some of the procedures in neonatal resuscitation are aerosol generating procedures like ambu bagging and intubation. Then you have when it comes to the real management, you start with your usual A, B, C, D, E, F, G. So your A is for your airway, ensure that it's open and maintainable. So there are no secretions, and especially for the preterm infants, because they can sometimes be very hypotonic. Even when you've cleared the airway, when you place them down, the chin can fall on the chest again, obstructing the airway. Then your breathing, B for breathing, C for circulation, and then your D, E, F, G is don't ever forget your glucose. Now, thermoregulation is also very important, especially for the preterm infants. Hypothermia has both short and long-term adverse effects on the neonate, especially around the time of birth. I think hypothermia or the baby's temperature is something that we tend to underestimate. But studies have actually revealed that, first of all, in developing countries, hypothermia increases neonatal mortality by 5 times. And for each 1 degree Celsius decrease in admission temperature below 36 degrees Celsius, there's an increase in mortality by 28%. And then, of course, an increase in the chance of late onset sepsis by 11%. So it's important that we try to keep our babies as warm as possible as soon as they come out of the delivery process. Then your oxygen saturation monitoring. You want your target oxygen saturation to be between 89 and 95%. Dr. Kwarteng spoke a lot about oxygen therapy. Now, remember that you do not want a baby on supplemental oxygen to be saturating at 100% to avoid adverse effects. And you should know which respiratory support you want to give in what situation. So a preterm baby saturating at 97% in room air, but working very hard, will benefit from CPAP set at an FiO2 of 21%. You do not wean a baby off. Is a background noise from me? Cyprian.
Men of faith.
Come again. Cyprian, are you there?
I'm here, sorted.
Okay, all right. So saying that you do not wean a baby off respiratory support based on the SpO2 alone. You need to take into consideration the work of breathing as well. Sometimes the baby is saturating well, but the baby needs some kind of pressure support. And that's how come they end up using the accessory muscles. And that's where the CPAP comes in. Then cluster nursing is also very important. The clinical team should decide what needs to be done on rounds. And then they go in, do what needs to be done all at the same time, and then leave the baby alone. No need to be handling the baby excessively. You don't want a situation where this one is responsible for RBS. So the person goes, pricks the baby, comes out. Then another person wants to take a sample for full blood count, goes in and then handles the baby, comes out. Some of the critically ill ones tend to deteriorate with excessive handling, especially the severely asphyxiated ones. So you want to group it, organize yourself very well. You go in, you handle the baby, or quote and unquote, you disturb the baby at one time and then you leave the baby alone. This will also help reduce the risk of exposure for the staff, as well as help economize the use of the PPEs as well. We're always complaining that we don't have enough PPEs, but if you have 3 members of the team going in at different times, doing things that could otherwise have been organized and done at the same time by one person, in the long run, it helps save some of our PPEs. Then you want to treat any underlying or comorbid conditions. Example, complications of prematurity, transient tachypnea of the newborn, sepsis. Most times, the baby is not even on admission because of COVID, but rather other newborn conditions. So it's possible that the baby would have been brought because the baby is turning yellow, or the baby was asphyxiated at birth. You give your antibiotics if indicated, according to your unit's protocol. So antibiotics should not be routine for babies of COVID positive mothers. Then nutrition, okay? So here, as always, breast milk, breast milk, breast milk. Okay, as my boss will say, breast milk is golden. At the end of the day, breast milk is a magic potion. You do not want to forget about your breast milk. If the mother is not in a position to put to breast, she can always express. And of course, appropriate PPE at all times. So this slide basically just summarizes the various case scenarios, okay? The first one, you have a well baby and well mother. So the mother is COVID positive, but they are both fine. In this situation, the recommendation is that baby stays with mom, is exclusively breastfed, mother practices hand hygiene and wears a mask all the time. In some centers, the recommendation is that once a baby is with the mom in the same room, the baby should be put in an incubator. Others also insist that the distance between mother and baby should be at least 2 meters or at least 6 feet. But whatever be the case, the mother needs to practice hand hygiene all the time and then wear a mask before and whilst handling the baby. The second scenario is when the baby is well, but the mother is sick. So the mother is sick enough such that she cannot care for the baby. Now here, the ideal is for the baby to be taken care of by a well negative COVID caregiver. Okay, so in such a situation, as soon as the baby comes out, there shouldn't be any postnatal contact between the mother and the baby. Okay, but here again, it needs to be discussed with the mother even before the baby comes out. The third scenario is when you have your sick baby and sick mother. So in this case, the baby needs to be admitted to the neonatal isolation unit. Strict PPE. Mother cannot visit for at least 10 days and then expressed breast milk all the way. Okay. All right. So another concept or another source of controversy has been with regards to rooming in. Okay. Now, early and close contact between the mother and the neonate has many well-established benefits. Rooming in has been a concept that is accepted worldwide. Funnily enough, it's said that human beings are the only mammals who separate mother and baby after the baby has been born. Current evidence suggests the risk of a neonate acquiring COVID-19 from the mother is low. Further, some data actually suggests that there's no difference in the risk of COVID-19 infection to the neonate, whether a neonate is cared for in a separate room or remains in the mother's room. There is, however, a potential risk of transmission to the neonate via contact with infectious respiratory secretions from the mother. It could be from the caregiver as well, or any other person with COVID-19 infection, including just before the individual manifests symptoms when the viral replication may be highest. As such, it's recommended that all caregivers should practice infection prevention and control measures. That is wearing of the mask, practicing hand hygiene, etc., before and while caring for a neonate. Literature from China actually recommends separating babies from positive mothers for 14 days soon after delivery. But quite a number of other guidelines, like the UK guidelines, they lean more towards keeping both baby and mother together and encouraging breastfeeding. And that is what is generally accepted and recommended, since there's still a very low rate of perinatal transmission. So the ideal setting for care of a healthy term newborn while in the hospital is in the mother's room, commonly called rooming in, like I mentioned earlier. Routine separation of mother and baby is not promoted. For babies rooming in with mothers with suspected or confirmed COVID-19, the following measures are expected to be put in place. Mothers should wear a mask, practice hand hygiene all the time during contact with your baby. They should wash their hands using soap and water before touching their child or expressing breast milk, either by hand or with a breast pump. Of course, the breast pump must be thoroughly cleaned after each use. The issue is that the determination of whether or not to separate a mother with confirmed or suspected COVID-19 and her baby should be made on a case-by-case basis. One case report looked at one baby whose COVID-19 positive mother provided unrestricted attachment and regular breastfeeding while implementing strict hand hygiene rules. And the baby never turned positive, at least up until the first month of life. Several studies have looked at cohorts of babies born to COVID positive mothers who roomed in with their mothers and were breastfed, and upon follow-up, none of them turned positive. A New York study followed up a cohort of about 82 newborns born to COVID positive mothers who roomed in with their babies and were exclusively breastfed after birth. The babies were kept in closed incubators for the entire duration that they were in the hospital, and they were tested at 24 hours of life and 5 to 7 days with a real-time PCR, and none of them were positive. Granted, the follow-up was pretty short, 1 week, but even then it still accounts for something. However, there are times when separating mother and baby cannot be helped. So when is separation necessary? Mothers who are too ill to care for their babies, mothers who need higher level of care. So a mother who will require mechanical ventilation, a mother who needs to be moved up to the high dependency or would require ICU monitoring. WHO states that whenever a mother is seriously ill due to COVID-19 or when other complications prevent her from caring for her baby or breastfeeding her well baby, she should be encouraged to safely express her breast milk and have it offered to her baby. Then, of course, when the neonates are at higher risk for severe illness. So if you have a very preterm infant, one who would say 900 grams, 850 grams, etc., etc., or infants needing higher level of care. So suddenly you have a baby who is saturating in room air, and then the next minute the baby is working very hard. You have to escalate the care. Such a baby would have to be separated from the mother. So like I mentioned earlier, for newborns that need to be separated from the mothers, this must be discussed with the mother before the delivery, and the baby taken away soon after the baby comes out without any postnatal contact. Of course, sometimes you cannot envisage how the baby will come out, so the situation can change. So when can they eventually see their babies? As soon as possible. So they said mothers with suspected or confirmed COVID-19 infection may be allowed to come into contact with their babies, one, after at least 10 days since their symptoms first appeared. In some centers, if the mother had a very severe illness or reaction, was critically ill due to the COVID, or is severely immunocompromised, they would actually wait up to 20 days before she comes into contact with her baby. Then another criterion is that at least 24 hours should have passed since their last fever without the aid of antipyretics. So breastfeeding. So breastfeeding, this slide is dedicated to Dr. Planjou, if she's listening. Recommendations on mother-infant contact and breastfeeding must be based on a full consideration of not only the potential risks of the COVID-19 infection in the baby, but also the risks of morbidity and mortality associated with not breastfeeding, the inappropriate use of infant formula milk, as well as the protective effect of skin-to-skin contact. So in our setting here, where we've all agreed that the benefits of breastfeeding totally outweighs the benefits of not breastfeeding. We have situations where mothers who have started formula come in, bring their babies in with severe dehydration and whatnot as a result of diarrhea. WHO recommends that mothers with suspected or confirmed COVID-19 should be encouraged to initiate or continue to breastfeed. Mothers should be counseled that the benefits of breastfeeding substantially outweigh the potential risks for transmission. Current evidence suggests that breast milk is not a likely source of infection and thereby does not support abstaining from breastfeeding nor separating mothers and newborns. Again, the precautions whilst breastfeeding or expressing milk are the same. Washing of hands with soap and water before touching the child or expressing breast milk, either by hand or by pump. Then the need to wear a mask when they are less than 6 feet from the baby, including when feeding at the breast or from a bottle, and when expressing breast milk, either by hand or with a breast pump. Again, WHO states that whenever a mother is seriously ill due to COVID-19 or when other complications prevent her from caring for and or breastfeeding her baby, she should be encouraged to safely express her breast milk and have it offered to her baby. Testing. Testing is also a topic where there was a bit of controversy about it in newborn care. Ideally, testing is recommended for all neonates born to mothers with suspected or confirmed COVID-19, regardless of whether there are signs of infection in the neonate or not. Ideally, that's why I put the word ideally in red. Now, in areas with limited testing capacity, testing should be prioritized for neonates with signs suggestive of COVID-19 and meet the case definition, as well as, those who would require, those with exposure who require higher levels of care. So like I mentioned earlier, baby with a positive mom who suddenly needs CPAP when he was initially stable in room air. So the umbrella here is those whose mothers are positive. Then you decide, does this baby have signs suggestive of COVID-19? I didn't mention case definition and whatnot because yesterday our lovely presenters took us through all that, and it's similar for newborn babies. But in our setting here, the takeaway message is that there is no need to test well babies. If the baby is well, then there's no need. In the ideal place, so long as a baby is born to a positive mother or a suspected COVID-19 mother, the baby qualifies to be tested. The optimal timing of testing after birth is unknown. There's still a bit of controversy surrounding the timing of the testing in newborns. It's been found that early testing may lead to false positive. Example, if the neonate's nares or nasopharynx and or oropharynx are contaminated by the SARS RNA in maternal fluids, okay? That means that when you go and you swab the nares, it's likely that you would pick up contaminants and you'd end up with a false positive. So the recommendation now is that, of course, at least for most centers, they prefer to wait and test at least 24 hours old. I thought I should mention something on counseling. Most of the time, we tend to forget about the mental health aspect of the mother, okay? I mean, pregnancy is supposed to be a time of joy, you know? Probably she's been anticipating it for a long while. She suddenly gets pregnant and now she's not sure what could happen because she's tested positive. Will my baby come out okay? Will my baby test positive? Will they separate us? A whole lot of things. So psychological support for the mother is necessary, especially in cases where mother and baby had to be separated at birth. Studies have revealed that most of the concerns that result in anxiety and depression can be addressed through constant education and counseling, especially since it's been revealed that the socio-demographic influences of the pandemic affect pregnant women equally, irrespective of their COVID status. So some of the sources of anxiety and depression include anxious about vertical transmission to the baby. It's been found that some even hitherto were considering delivering in the hospital are now considering a home birth, transferring the infection to the baby through breastfeeding, not having enough information about the whole condition, family not being tested as contact tracing might not be in place. Some consider delaying baby's immunization due to fear of transmission in the hospital. Okay, then transmission to other children in the family. I mean, we all live in a one-room apartment. If you tell me that for 14 days we should self-isolate, what about the other siblings? Where are they supposed to go to? And even financial insecurities as a result of the pandemic. Discharge planning. So babies may be discharged when stable. I put the word stable in quotes because exactly what does stable mean anyway. So we tend to discharge as soon as the baby is weaned off respiratory support. So baby is saturating well in room air with very little or no work of breathing, etc. Temperature has settled. Because then again, we also have the challenge of space. Unfortunately, we have only one isolation room. So it's difficult to keep the baby there for the recommended, say, 14 days or something. All babies born to COVID-19 positive mothers should have follow-up and ongoing surveillance after discharge. Family members need to be educated about the steps to take in order to reduce the risk of transmission to the infant. So in a situation where it's the mother who is positive, okay, so reducing physical contact, hand washing, wearing of masks. And also they need to be educated on the need for immunizations for the infant. So we've had situations where last year when COVID peaked, we had quite a number of mothers who stopped going for their weighing and immunizations because they were scared, which is very understandable. So they need to be educated on the need for immunizations for the infant, as well as on common danger signs in the neonate: fever, poor feeding, signs of respiratory distress, etc. Babies and mothers who are discharged before completion of the 10 to 14 days isolation in the hospital should be advised to self-isolate at home. Again, this can be very difficult because you have no idea how the home setting is. But then again, it also helps when you explain the situation to the mother, to the caregivers. Once they understand what is at risk, they will do what they can. So what do we know? At the end of the day, as a friend of mine will say, intimate krakra is saying, when it comes to newborn care, there's still no evidence supporting vertical transmission of COVID-19. There's no specific treatment modality for COVID-19 in neonates. Hence, babies must be treated symptomatically and on a case-by-case basis. It's preferable not to separate mother and baby. Ideally, that is the best. Breast milk still reigns supreme. In the event that either baby and or mother are too ill to be kept together, expressed breast milk is still recommended for the baby. Remember that the risk of mortality is 14-fold higher in infants who are not breastfed. Okay, over 820,000 children's lives could be saved every year among children under 5 years if all children 0 to 23 months are optimally breastfed. A well caregiver may be assigned to take care of a well baby whose mother is too ill. The numerous benefits of skin-to-skin contact and breastfeeding substantially outweigh the potential risk of transmission and illness associated with COVID-19. The World Health Organization recommends exclusive breastfeeding for the first 6 months of life, followed by continued breastfeeding with appropriate complementary foods for up to 2 years and beyond. Early and uninterrupted skin-to-skin contact, rooming in, and kangaroo mother care also significantly improve neonatal survival and reduce morbidity and are recommended by the WHO. These have not changed in the COVID era, okay? The benefits definitely outweigh the risks. These are my references. Thank you very much.
Thank you very much, Dr. Nana Rekubrebe, for the wonderful presentation. We'll take the next presentation from Dr. Della Adzosii. Dr. Adzosii is a pediatrician at the Korle-Bu Teaching Hospital. He's a member of the cardiac team over there. He's also the chairperson of the Greater Accra Division of the Paediatric Society. And he's a key member of the COVID-19 management team. Dr. Adzosii is going to talk to us about COVID-19 and going back to school, the issues that we are supposed to consider in terms of public health and more. So Dr. Adzosii, if you are ready, please go ahead.
Okay, hello, Cyprian.
Yes, I can hear you.
So like I said, I believe we've all been asked one of these questions during the period of the pandemic. And I mean, I've certainly had my fair share of it. And this highlights the fact that there's always a knowledge gap between what we, even as health workers, know and what the general public is hearing. And it'll be interesting to know that some of this question comes from as colleagues, because a lot of things are new and a lot of things are evolving. So I speak to you both as parents and as public education in some of these issues that I've highlighted here. So essentially, what is our focus with this presentation? We are seeking to continue to highlight the importance of all existing protocols through its communication with the public, and we need to go out there, correct, that is our presentation, and we need to like keep upon us as that have been made with other child health related issues. And then important for me is we embrace innovative ways of carrying out our professional duties, because things are not the same and they probably won't remain the same again. So we need to probably have to do some old traditional ways of. And we also need to remain well informed through continuous education. I mean, the worst thing you want to have is where the judge has difficult questions and we are not sure what responses to give them. So we need to always inform as well, inform ourselves, helping us to be ready to inform the general public. Also important is for us to identify and form strategic partners in our localities so that we can preserve the health of children much better. We can't do it alone. We need everybody else within the community, the chiefs, the traders, the cleaners, in order to preserve the health of our children. And then we must see, we always talk about hand washing for prevention of diarrheal illnesses. But the pandemic has even given us a bigger platform to push home the idea of hand washing as a key component of preventive health among children in Ghana and indeed the rest of the world. The scope of this topic, as you can see, is quite broad, but they are simple things, and I'm sure you are already having a feel of the fact that these are things that you already know, but they remain important in the journey to achieving a strong post-pandemic healthcare delivery system for children in Ghana, which is why we all need to get on board and embrace the issues as and when they come. We don't want to end this pandemic and realize we don't have systems in place to continue caring for our children. I will highlight a few of them, and then certainly we are open to insights from you out there on the ground, because we really appreciate the good work that you are doing in whichever little place that you think you are in. Everywhere is a big part of the bigger problem we are trying to, a bigger solution that we are trying to enact among the children. So I have 10 points that I want to share with you. And I'll start with this one, which is just for us from a public perspective, we need to continue to highlight since the pandemic started about 2 years on our awards, minimizing the number of visitors. It's also important that health facilities and health workers engage people in their catchment areas to involve them in the care of children during this pandemic, because you don't want to wait for the problem to come to your doorstep. So if you are in any your facilities in the community, reach out to the people there, see how you can work together to ensure that the children are efficiently taken care of. And within the facilities too, we are drawing attention to the need to adopt appropriate appointment systems and protocols that avoid overcrowding of wards without compromising on the care of it. It's time for us to be innovative, and I know a lot of us. Thing I want to draw attention to is what I call preserving gains that we've made. We spent considerable amount of both financial and human resources in trying to achieve important public health interventions to safeguard the health of children. And so it's critical that even as we tackle the pandemic, we don't lose these gains, or we'll come back to them. I mean, it's obvious that finances are becoming an issue in the country. So it's key that we do this thing. Safe delivery of comprehensive newborn care, as has been said by my the previous speaker remains paramount, so I'll not here as well. So we need to really hold on to it, especially exclusive breastfeeding. Childhood immunization as a component of the last one, which is the child welfare clinic, is also critical. We need to engage our caregivers and find ways of streamlining appointments to the child welfare clinics, and also information to assuage them from their child welfare clinics. The good thing is that the numbers are increasing at the few places that I've been to, which means that a lot of fears are being done away with. But we need to continue, because every now and then I've met people who have still not come to child welfare clinic because of one fear or the other about contracting the virus in the health facilities, or whether taking the regular vaccines will create more problems for them. So we need to be ready for such questions. Then we've made gains in nutrition as well. If you look at our child welfare records, it's a big section is on nutrition, and we need to continue to highlight that component to both our parents and in whatever public space we find ourselves, because once again we know that good nutrition improves the immunity of the children and increases the chances that we're able to recover effectively from the virus if they do come down with it. Then diarrheal diseases, we've made some important gains there as well, and we need to preserve. We need to highlight the importance again of hand washing, the use of zinc, ORS, and other oral rehydration therapies, especially at home before seeking care in the hospital. Then the last gain on my slide I want to highlight is malaria prevention. We've done a lot of good work in those areas as well. We need to continue to highlight the importance of insecticide-treated nets, prompt treatment of malaria, of the infectivity. So these are things, I'm sure the other ones that for now I think we need to pay attention to. What we should do about children with chronic illness, asthma, sickle cell, HIV, TB, and so on and so forth, cardiac. And these children are particularly at risk of succumbing to the effects of the virus because of the nature of their immunity. Attention to them, and because they are already an organized group of patients in quotes, it becomes a bit more easy to address their concerns. So we are saying that we ensure that they strictly have well-defined protocols, and when arrange and discuss management of some of these children with facilities that are closer to where they are, so that we can reduce the transport that also poses coronavirus concerns. So if there are facilities nearby that we are sure can do some of these things, we should empower those facilities so that they can take care of the children for us. Then the fourth thing, which has to do with school, we're no longer reopening, we're already in the school, came up. We're just reiterating the point that as healthcare professionals, we should ensure that all protocols for safe reopening of schools are strictly adhered to. The Ghana Education Service line, and I think it speaks the same language. It's also important that we work with the schools and then with families to ensure the implementations of these protocols, because there are some schools that have had huge challenges because there's that lack of coordination or collaboration between the families, the schools, and the health professionals. And I think that the PTAs must be empowered to take on some of this. When these three individuals in code work together, then the protocols are likely to be adhered to in the schools, and we don't have situations where schools get closed down. Then another important thing for us as far as the health of children is concerned is play and recreation. We know the restrictions that the pandemic has played on the children, but we also do recognize the importance of play and recreation in the overall development of the child. So we encourage that we find innovative ways of ensuring that these children play and under supervision, they can be allowed to play. Of course, they ensure that they have good hand hygiene, they distance well. Some sports in particular, especially the non-contact ones, are things that we can look at: walking, aerobics, things like table tennis, kick about. So if they are not going to play football as a group, they can stand at one end and kick the ball to each other. So those things keep them active and also reduces the chances of them becoming obese, which is one of the things that we're having to deal with in this pandemic. And the sixth thing I want to draw attention to is mental health issues. And that is something that we cannot throw away. I mean, health, as we know, is both physical, emotional, mental, and social. So the mental aspect are undergoing a lot of stress. I mean, I know my children who are dealing with one kind of stress or the other. Thankfully, we have a society that has a lot of people who are equipped or masters in this area. We can certainly fall on their knowledge to assist us where need be. But I've highlighted a few things that we can point out if we have to do any kind of public education: secondary numeracies, aggressive behaviors, regression of school performances, risky behaviors, and so on and so forth. If any parent complains about any of these things, it's a good time to have a conversation and consider whether the child may be dealing with any mental related issue. I've highlighted on this slide useful things that can be done to prevent things from escalating. So families need to work at this. You need to be open and have conversations with their children about COVID-19, set routines for them. A lot of routines were broken during the lockdown, so children were sleeping and waking up at odd hours, and so it's having an effect on some of them even as school has open. So families and healthcare professionals ready to the family so that when these situations happen, they know where to go. The schools also play an important role. Schools must make the provision for the classrooms to have discussions on issues of COVID and how they are individually coping with it. The seventh thing I want to highlight is the problem of emerging health challenges. I remember during the early days of the pandemic, our ICU was, the pediatric intensive care. Instead of having COVID cases, we're having more aspiration pneumonias from accidental poisoning, and I'm sure you can guess why that was happening. We have to tackle these preventable issues well, else it will add to the burden that we are encountering. I mean, if you have to deal with maybe a corporate plan, and then unfortunately the child who's run tourism and been given palm oil and aspirates on you. That's something you don't want to have to deal with. So we need to go and the real pandemic issues. So these are some tips that you can share even as you interact with your patients and the community, and hopefully we don't have them. So the eighth abuse, especially child sex abuse, tended to even in schools, because children are closing earlier and parents are unable to pick them up in the middle of the school. Sometimes when you get to the schools, their children are just all over the place, and even at home, when they get home early, the attention is not there because parents have to quickly rush back to work. I mean, or one thing or the other. So we need to be intentional protecting our children unit that is equipped with a lot of information to assist us when we chance on situations like that. There was just a news item this morning about child trafficking and child labor being on the increase, and that buttresses the last point I've made, that because of the economic hardships, children are becoming the economic solutions for families, and we need to pay attention to such issues as well. What things we can do is to be aware of the common pointers to it. So we need to empower our children to speak out. I find unplanned home visits very important because most perpetrators, movements of the caregivers are able and then take opportunity to do what they do. So we need to plan visits home so that we introduce an element of unpredictability, and that can become a bit protective. The ninth thing that I want to draw attention to, which was spoken of extensively by Dr. Reku Grobe, is the issue about newborn care. Okay, no pregnant mother must be denied comprehensive antenatal care, either directly or indirectly from the pandemic. We have no excuse for it. We have to find antenatal care, and that babies have comprehensive newborn care, and that mothers have the psychological support they need, even as they entertain their fear before, during, or after the delivery process because of the issues of the pandemic. The comment about people wanting to deliver at home is real. I mean, I know people who have kind of moved from one facility to the other because of the concern that this facility has been noted to have COVID patients. And that's since the delay in getting care for them, and the repercussions are something we don't want to have to deal with. The last slide is on breastfeeding, which has also been spoken of extensively by the previous speaker. And I want to add the fact that the benefits of breastfeeding far outweighs the risk of transmission of COVID-19. And I know she also emphasized that. So we need to embrace that and preach that unequivocally. So duty calls on all of us. In addition to the clinical care, we need to go out there and do a lot of public education on all the available media platforms. We need to be strong advocates in the communities we are, in the facilities we have. The children need what they need to be catered for. If it's PPEs that are not being provided, we shouldn't be quiet and say, that is the situation on the ground. We need to go the extra mile. Pediatricians are known to go the extra mile, so let's live up to our name. And then in situations where you have schools in your neighborhood, you should be able to volunteer to go there and say, hey, can we look at how we can keep the children safe? We're really not taking anything out of us. And the schools will be more than happy to have us assist them. I know there's a school that contacted me and said, oh, can you help us with the protocol for A, B, and C? And it tells us that there's a need out there. And so we should be willing to work with our neighborhood schools and other facilities and see how we can bring our unique training to bear on them. Let's all get involved. Thank you for your attention. I've relied on sources from WHO, UNICEF, the Center for Disease Control, and Ghana Health. My acknowledgement to the peer committee whose idea was for us to have this. The team I worked with, led by Joycelyn, and then Dr. Gladys Lomotey, who's been my co-author of what I've presented. This is what happens when you leave your 2-year-old to your laptop when you're waiting to do a presentation. Thank you very much, and we'll take any questions from you.
Thank you very much, Della. Like I said earlier on, you can drop your questions in the chat and then we'll address them one by one. I'd like to thank everyone for staying with us throughout. We are not done yet. We have one more presentation. And this is going to be done by Dr. Joycelyn, who is a consultant pediatrician and infectious disease specialist at the Korle Bu Teaching Hospital. She's a very key member of the national COVID-19 management team. And what she's going to tell us is about the next steps in COVID-19 management in children. Okay. So,
Good
Dr.
afternoon.
Adabie, yes.
Yes. Secret,
All right.
please, can you?
Yes, I can hear you and I can see your slides.
Okay, let me just try and put it. Okay. Good afternoon, everyone. We started in the morning, in the afternoon. This is going to be very short. Thank you for your attention. Thank you all speakers. After all that has been said, what next? So we've heard all this. So what happens practically? What happens when a child comes to you? What do you do? And so that's just what I'm going to summarize in about 2-3 minutes. This is the beginning of the step we are taking. We said second wave. Are we going to see a third wave? So that whatever happens, we are going to be prepared. So we are just going to talk about these 5 points: guidelines, isolation areas, training, networking, and data collection. This is what is going to prepare us to handle any pediatric cases that come our way. So with all that we've been doing, we also prepared guidelines. It's almost ready. We're just going to send it for few external reviewers. That is, when I say external, people who are not within the group that we have worked in, should be available by early April, God willing. Find it on websites, Society of Ghana websites, and also we can share on various platforms. Now, updated as new evidence is made available. This is going to be used in isolation. We know that we have the Ghana guidelines. So, but there are some things you're not going to see that you see in the Ghana guidelines that you don't see in ours because updated is. So certain drugs, I mean, a lot of talk has gone on about some drugs, some things that there's been no evidence found, you're not likely to see in our guidelines. Please use it, and you can contact any of us if there's something you don't understand when you're using the guidelines, or if there's something that you think should be in, feel free to let us know together. What about isolation? From today, please, when you go back to your facilities, you can handle COVID cases, depending on what your facility is. You don't need to, you can have a very high-tech place like this or a very simple room like this. Okay, it's just for you to identify a place where you can have a child. The child is, and suddenly we are all over, where should I send the child? But from what I said, if you've done your training, you have your guidelines, you realize that depending on the situation, if it's a moderate case, you can handle. If it's somebody who needs to be referred to a higher facility, then you do that. But as much as possible, look for a place. Ventilation is key. Have an oxygen source, washroom facilities that will be self-enclosed. A place that can don on and off. Your PPEs should be in place. When I say it should be safe, you should be able to view your patients from outside. It shouldn't be a place that is completely barricaded, so that if there's a change in condition, you'll be able to see the person. So if you see, it's just a simple, a 2-bed room, 3-bedroom, 1-bedroom, and just let us know. If you're going to need some training as well. Okay, training on how to triage effectively. IPC, we've talked a lot about going through IPC. You can go on about how to don on and off. Training can be in virtual or in person. So once you identify the place, the next step is some training. Sometimes when you hear it, it sounds so easy, but it's the practice that may be a bit challenging. But let us know, and then we are keen to support you where you are. People can assist you either from Kumasi, from Accra, or wherever. We'll have people in place who will be ready to assist you. We work together with the National Case Management Team, as well as the Paediatric Society of Ghana. And then networking. So when you have found your isolation site, you want your training. Also, I think that we should have sort of, it's a group, because for the National Case Management, there are all these systems in place, so that if somebody can say, oh, I have this child, 5-year-old, blah, blah, blah. Where is the child? Okay, we can take the child to this place. Where is it closer? Kind of system in place. Otherwise, when you have a patient, you become so stressed and where to take the child. I want us to make things very simple for ourselves. Some manage at home. And in the guidelines, we have comprehensive place where we've talked about home management, what you actually do when you have a child at home, how you monitor the child. So when we network together, we share ideas and we make it easier for ourselves, especially when you have to refer the person somewhere. Let's not forget collection. How cool was it to see Dr. Nana's data, telling us about how many babies, how many mothers. That's the sort of thing we should have done by so easy, but it can be done. And so currently 8 sites have been recruited to start collecting data, okay? I hope that we'll be able to do quarterly there's a platform, okay, from March to December or March to June, what have we seen? What's the characteristics of the patients that we have seen? Just for people, kind of information, as is done elsewhere. This is something that can easily be done if we all work together. It can also inform our practice. If we realize that anytime we put this child prednisolone, it doesn't work so well as when we are doing methylpred. Okay, what should we do? So all these things, and it's just real-time data that is going to be collected. There's already a protocol in place, a study in place mainly for adults at Ghana East and Pentecost Conventional. We just want to latch on that and it to include children. And as more sites are interested, we should include them so that we pediatricians will also just have data. So what I'm saying is, please, data. It's a very new disease. It's something that is exciting, and it's something that we should be able to learn from for the future. And so I just want to thank all of you for time that you spent with us since yesterday. Comments and contributions are welcome. I really acknowledge all those who took in making this happen, both the guidelines. I know how busy everybody was and had to pull people all the time, and I'm really appreciative, including our chairperson. Thank you very much. Cyprian, over.
Okay. Thank you very much, Dr. Adabie. Now we'll take some comments from the chairman of the program. Before that, I would like to remind everyone of the evaluation forms. It's in the chat box, so please fill it so we can know what went wrong, how we can improve on our presentation. Thank you very much. Dr. Popelampo, may I have your comments, please?
Right. So I think all this session, which is highly packed, and I'm sure those who missed out a bit, as I observed their participation, we moved from around 50 all the way to about 160, and then now we are back to about 130. In case somebody missed out on something, I think the organizers have all the slides to share. But then this has been a very useful seminar, and I wish, just like the previous speaker said, we all get down to work right away and just get a space in our various hospitals to manage these cases. Secondly, would also want to say that COVID comes with some things that, if learned properly, can go a long way to help us in managing infectious diseases generally. One can see the collateral benefits that we are getting in the much reduced or almost absent cases of cholera this year and last year. And so maintaining these IPC principles, I think, is also very key, so we don't lose them. From the Ebola episodes, when we're preparing up to now, when we had to prepare for COVID, I think we lost that IPC principle. We had to retrain. I hope that after COVID, we will not easily just lose the IPC trainings that we've all acquired, rather maintain it, and definitely is going to reflect in the benefits that we're going to get in the incidence of other infections, being very enlightening and very profitable. We hope to have more of such. Thank you all presenters, and wish to see you again. Thank you.
Thank you very much, Dr. Popelampo. on behalf of the Paediatric Society, I would want to thank you very much for taking up this chairmanship position under such short notice. I also want to thank all the presenters for putting this together and the organizers. You've done a very, very good job over the past 2 days. We've learned a lot. We say that Aiko, and God bless you. And all the participants, we are most grateful for your presence, your contributions, and your questions. God richly bless you. So we'll end this with a short prayer as we started with the prayer. Father, I want to thank you for being with us throughout this event. I want to thank you for the lives of our chairman, our presenters, our members who all contributed to the success of this. Father, we pray that whatever we've learned will be useful. We will remember, we will apply it in our everyday practice. This and many more we ask in Jesus' name. Amen. Okay, so have a nice weekend and thank you once again.
Thank you, Cyprian.